doctors. So today I'm going to discuss about the Mrcp basis, respiratory station, and I'm going to talk a bit about the case of bronchiectasis. Bronchiectasis and chronic bronchitis, they are very common cases in Mrcp basis respiratory station. So you must be well prepared for this case. So let's start our case. This is a case scenario. Mrs. Smith, a 45-year-old woman, presents to respiratory clinic with a history of chronic cough, copious purulent sputum production, exertional dyspnea, and occasional hemoptysis. So she has a chronic cough and she has a purulent sputum. So it can be either chronic bronchitis or it can be bronchiectasis. There's some exertional dyspnea also, and she has some hemoptysis as well. Okay, but this is, as you know, that this is a short station or short case, so no need to take any history on the respiratory station. So let's move on. So first of all, you go once you enter the room, you will introduce yourself and take consent, and then you start with a general inspection. So in the general inspection, Mrs. Smith appears tired and breathless at rest. And important finding which we should look for is the digital clubbing, which may indicate chronic hypoxia and lung disease. And here you can see clubbing here, very evident in the hands. Then you will move on and do the respiratory examination. Again, you start with inspection, barrel-shaped chest, which is suggestive of chronic airflow obstruction, or sometimes there may be asymmetrical chest expansion with reduced movement on the affected side. And this is how the barrel-shaped chest will look like. You will go on and do the palpation. So you may find decreased tactile parameters over the affected lung segment. There may be some chest wall deformities like Harrison sulcus or pectus excavatum, which is indicative of chronic lung disease. And here you can see this is the example of pectus excavatum. Going to percuss, hyperresonance may be noted over the affected segment, so indicating air trapping. And finally, you're going to do the auscultation. Coarse crackles and wheezing are heard bilaterally, particularly prominent in the lower lung fields, and reduce breath sounds and prolonged expiratory phase indicative of airway obstruction. Remember, when even though this is a respiratory station, just do a brief cardiovascular examination as well. So in that case, because the patient has presented with the exertional dyspnea, so the minimum you can do is listen for the heart sounds. So do the cardiac auscultation, and as well as look for any JVP. So these two you can add in your examination. Coming to the differential diagnosis, there can be some infections because recurrent respiratory infections, particularly the bacterial infections, these are the common causes of bronchiectasis. And normally the pathogens Haemophilus influenzae or Streptococcus pneumoniae, Pseudomonas aeruginosa, and Staph aureus. These are all cause inflammation and damage to airway walls. So these can lead to bronchiectasis. So recurrent respiratory infection is one cause. Obstructive lung disease, COPD, asthma, and cystic fibrosis. These are conditions which are associated with chronic airway inflammation and obstruction, so increasing the risk of bronchiectasis development. And then cystic fibrosis, we all are aware this is a genetic disorder, and there is a dysfunctional chloride channel, so leading to thickened and sticky mucus production. And this mucus then obstructs the airways and predisposing individuals to recurrent infections and bronchiectasis. Coming to other differential diagnoses, sometimes immune deficiencies like primary immunodeficiency, such as common variable immunodeficiency or selective hemoglobin A deficiency. This can impair the immune response against respiratory pathogens. So it also increases the susceptibility to recurrent infections and bronchiectasis. Aspiration, inhalation of foreign substances such as gastric contents or food particles, air pollutants, any type of aspiration, it also can sometimes lead to chronic inflammation, which causes damage to the airway epithelium, so causing bronchiectasis. Allergic bronchopulmonary aspergillosis, we know it is a hypersensitivity reaction to aspergillus fungi, so leading to allergic inflammation and bronchial wall damage. Autoimmune disorders like rheumatoid arthritis and inflammatory bowel disease, these are associated with systemic inflammation and also can lead to bronchiectasis. Primary ciliary dyskinesia, again, the genetic disorders, these impaired ciliary functions, so lead to ineffective mucociliary clearance, and these are recurrent respiratory infections. Bronchial obstructions due to any tumors or foreign bodies or bronchial stenosis also can cause chronic inflammation. And finally, there's idiopathic bronchiectasis as well. So in some cases, the exact cause may not be identified, so it is termed idiopathic bronchiectasis. So I mentioned many differential diagnoses here. If you can remember 3 or 4 of them, I think should be enough. How we'll approach to the case of bronchiectasis. Sometimes they will ask how you'll approach this patient. So always start with the clinical history. So we want to gather detailed history, and particularly we are interested in about the duration of symptoms and any history of recurrent respiratory infections. Past medical history is important, including asthma or cystic fibrosis, any immunodeficiency disorders, autoimmune conditions. Smoking is very important, occupational exposure, environmental factors, and family history of respiratory conditions or genetic disorders. And then obviously you're going to do the physical examination. So we're going to assess for any signs of chronic respiratory disease like digital clubbing, barrel chest, or cyanosis, and look for any underlying systemic conditions or comorbidities. So systemic conditions, what we can look for, suppose if we are thinking about any autoimmune diseases, so maybe the patient have other findings like rheumatoid hands or any deformities on the hand, which can lead to the cause of the bronchiectasis. Sputum analysis, this is important because to assess for the neutrophils, bacteria and mucus plugs, and microbiological culture and sensitivity testing. And also we want to do the AFP staining and culture as well. Yeah, about the imaging studies, we want to do the chest X-ray. So this is the initial modality for evaluating the lung pathology. So look for the signs of bronchiectasis, particularly we're looking for any tram-line shadows or any ring shadows or cystic changes. So here you can see some shadows are there, the ring shadows. And high-resolution CT scan. High-resolution CT scan is it's a gold standard for diagnosing bronchiectasis, which evaluate for the bronchial dilatation, any bronchial wall thickening, any mucus plugging, and associated lung parenchymal disease. So it also helps to assess the extent and severity and distribution of bronchiectasis. We also want to do the lung function test, the like spirometry, which assess for the airflow obstruction, restriction, or mixed patterns. Lung volumes and diffusing capacities to evaluate for lung hyperventilation, gas exchange abnormalities, or restrictive lung disease. Laboratory investigations also we want to do the CBC to look for any leukocytosis. Serum immunoglobulins levels are important to screen for any immunoglobulin deficiencies, and autoimmune markers to check for evidence of autoimmune conditions. Obviously, if it is clinically indicated, then we want to do these blood tests as well. Sometimes we need to do the specialized testing like bronchoscopy with bronchial lavage, and this is important to for the evaluation of airway anatomy, to visualization of airway lesions, or obtaining samples for culture and cytology. Genetic testing, obviously, if we are suspecting genetic disorders like cystic fibrosis or primary ciliary dyskinesias, and underlying cause assessment, as I told you before. So based on the initial investigation, we investigate and address the underlying specific causes or contributing factors identified during history examinations and investigations. Briefly, how you'll approach. So always divide approach whenever the examiner asks to approach, always divide into different sections. So there is a pharmacological therapy. We want to try the bronchodilators, inhale short-acting or long-acting bronchodilators for the bronchospasm and improve airflow. Mucolytics play a major role like hypertonic saline, recombinant human DNAs to reduce the sputum viscosity and enhance the clearance, antibiotics to teach the acute exacerbations for chronic bacterial colonization to suppress the bacterial growth, anti-inflammatory agents. Sometimes there is a role of inhaled corticosteroids, especially the patient who have concomitant asthma or eosinophilic inflammation, and immunomodulator therapies. Sometimes azithromycin may be considered for anti-inflammatory and antimicrobial effects in selected patients. Then this is the first group, pharmacological therapy. Then the airway clearance techniques, physiotherapy such as chest physiotherapy, posture drainage, percussion, and vibration to mobilize and remove then excess secretions. High frequency chest wall oscillations. These are the mechanical devices that delivers oscillations to the chest wall to enhance the airway clearance, and exercise, regular physical activity to improve the respiratory muscle strength. And treatment of underlying cause, obviously we want to management of the underlying infections, addressing the underlying infection like chronic sinusitis, underlying infections, chronic sinusitis, GERD, and these all contribute to the bronchiectasis exacerbations. Allergen avoidance, so minimizing exposure to environmental allergens or occupational hazards that can exacerbate the respiratory systems. Pulmonary rehabilitation, so structured program that incorporate exercise training, education, and psychological support to optimize the functional capacity and quality of life. Vaccination, important influenza and pneumococcal vaccination to reduce the risk of respiratory infection support. And finally, nutritional support, adequate nutrition and hydrations. These are important to support overall health and immune functions in patients with bronchiectasis. So this is how you're going to, if the examiner asks you about the management, divide it into the pharmacological therapy, airway clearance techniques, treatment of the underlying cause, pulmonary rehabilitation, vaccination, and nutrition support. So always try to be systematic. Coming to the other options, we also, I would like to include the surgical interventions. Sometimes in selected cases, we localize or severe bronchiectasis. Surgical resection affected lung segments may be considered, and obviously regular monitoring and follow-up, periodic monitoring of symptoms, lung functions, and imaging studies to assess the disease progression and response to treatment. So always remember, we need a multidisciplinary team. So we include the pulmonologists, respiratory therapists, physiotherapists, and nutritionists to optimize the patient care. This is briefly about the case presentation. So first of all, you're going to, again, as I told you, that always whenever do the presentation, divide into different sections. We start with introductions. I'll be presenting a case of 45-year-old male or female who presents with chronic respiratory symptoms, suspected bronchiectasis. Whatever written there, brief history, he or he has presented a persistent cough with copious sputum production for several months. Then you talk about examination. On examination, she appears breathless but not in acute distress. Vital signs within normal limits, and bilateral coarse crackles are heard on chest auscultation with reduced breath sounds. Assessment and management based on the history and examination. The primary diagnosis is bronchiectasis, and then you continue talking about the management plan, which include the pharmacological therapy for bronchodilators, mucolytics, and antibiotics as needed, refer to a respiratory specialist for further evaluation and consideration of pulmonary rehabilitation and patient education regarding airway clearance, whatever we have discussed before. And then finally, you'll talk a bit about the summary. So in summary, Mr. Smith presents with chronic respiratory symptoms which are suggestive of bronchiectasis, and the management approach focuses on symptoms relief, prevention of exacerbation, and multidisciplinary care to improve overall quality of life. So remember in the presentation, remember these headings: introduction, history, examination, assessment, management, summary, and don't stop until the examiner stops you and asks you some other questions. So I put some questions for you here. What are the potential complications? We already discussed. Complications, they include recurrent respiratory infections, chronic cough, hemoptysis, respiratory failure, bronchiectasis exacerbation, and also complications which are related to treatment like antibiotic resistance. How would you differentiate between acute exacerbation and chronic stable disease? So acute exacerbation is usually characterized by worsening respiratory symptoms. So there is an increased sputum production, and then there's a change in sputum color or consistency, maybe fever or systemic symptoms. Where a chronic stable disease usually presents with stable or gradually worsening symptoms without acute changes. Imaging modalities we already discussed. HRCT, it is the gold standard for diagnosing bronchiectasis. And normally we see in HRCT bronchial dilatation, bronchial wall thickening. There may be tramline shadows, ring shadows, and signet ring sign. How do you assess the severity of bronchiectasis in this patient? So severity assessment include obviously clinical symptoms, how is the frequency of exacerbation, lung function tests, imaging findings, and presence of comorbidities. Goals of treatment. The goals include symptom control. We want to prevent any exacerbations, improvement in quality of life, and preservation of lung functions and reduction of complications. So when would you consider surgical intervention for bronchiectasis? Very important question. So maybe consider if got localized or severe bronchiectasis, which is refractory to medical therapy. If the patient has a recurrent hemoptysis or bronchiectasis limited to a single lung lobe. So hopefully I've tried to cover everything in this bronchiectasis case. Hopefully it is helpful in your preparation for the Mrcp PACES respiratory station. Thank you very much, and I'll see you in my next presentation.